And this is a full spectrum of non-alcoholic fatty liver disease. You have a normal liver, you have liver with steatosis, that is fatty liver without inflammation or hepatocyte ballooning. You have NAFLD, steatohepatitis or NASH, which there is inflammation or hepatocyte ballooning. And then you have cirrhosis, increasing fibrosis leading to cirrhosis, hepatocellular carcinoma. 25% of the patients will be of the first type, that is NAFL. 1.5 to 6.5% per progress to NASH, and 0.5 to 2.6 per progress to cirrhosis. And this is what the liver biopsy looks like: ballooned hepatocytes with moderate inflammation, perisinusoidal and periportal fibrosis, and cirrhosis. So the overall prevalence of this disease is 35%, only NAFL, 1/4 is NASH. Prevalence of NAFLD in people with obesity is 80 to 90%. Patient with dyslipidemia, 27 to 92%. People with type 2 diabetes, 60 to 80%. So as you can see, this disease is very important because it's a very, very common disease. And prevalence of type 2 diabetes in patients with NAFLD is 22.5%. Patient with NASH is 43.6%. And there is a bidirectional link of increased risk. So why should we worry? Because there is a high risk of liver disease progression, NASH, higher risk of progression to cirrhosis, 20%, faster progression from one stage to fibrosis to the next, 14 years in NAFL, 7 years in NASH, higher risk of VSLD complications and mortality, increased risk of hepatic and non-hepatic malignancies. There's an increased risk of diabetes complications once you have this syndrome, the greater atherogenic dyslipidemia, and independently associated with cerebrovascular and coronary artery disease. And the most common cause of mortality is coronary artery disease, and increased risk of microvascular risk. So we have a need for early detection. So in routine health checkup, we do ultrasound and fatty liver on ultrasound, abnormal liver enzymes if you find. But abnormal liver enzymes will be normal in 80% of this disease. Ultrasound may not be able to detect liver fat. So what do? You screen patients with overweight, obesity, prediabetes, metabolic syndrome, type 2 diabetes, hypertension, CVD, PCOS for NAFLD. Screen patients with NAFLD for diabetes and components of metabolic syndrome. And diagnosis requires a quantification of steatosis, grading of steatohepatitis, and detection and grading of fibrosis. And the gold standard is a liver biopsy, but as you know, liver biopsy is invasive, can't be done in everyone, and most patients will not agree for a liver biopsy. So there are better methods. So better methods are that you have clinical lab tests, and we have some indices called FIB-4 index is the most common, and you have imaging modalities like ultrasound, computer tomography, MRI, and transient elastography. However, you must have heard of FibroScan. We have it in our hospital, and that is the most commonly used test for this. And then we have biomarkers. So the commonest thing that tell us that this patient has NASH is that liver enzymes are elevated, and then you have scores based on mathematical formulas, NFS score and FIB score. So this is what is called the FIB score. The app is available in Google. You can download it. Just enter the age, AST levels, platelet count, ALT level, and then you have the score. And if your score is less than 1.3, there is absence of advanced fibrosis. If it's more than 2.7, there is a presence of advanced fibrosis. And these two scores will tell us. Then in the ultrasound modalities, I told you ultrasound is the more commonest and the easiest available, but it does not tell you the diagnosis of NASH or fibrosis. It does tells you that an AFLD are present. And then you have the commonest use is FibroScan, which is the most cost effective. So how do you manage an AFLD? you have high risk groups, you catch them and you screen them for an NAFLD, that is pre-diabetes or type 2 diabetes, obesity, and two cardiometabolic risk factors, hepatic steatosis, ALT or AST more than 30. Then you do a history physical exam, rule out alcoholism, rule out hepatitis, and then you diagnose NAFLD. And prevention of that, then once you have diagnosed it, you prevent cardiovascular disorders, you can't prevent cirrhosis, and prevent by the management of obesity, diabetes, hypertension, atherogenic dyslipidemia. Present these two, and then you have a fibrosis risk stratification by FIP score, and that you have low risk, intermediate risk, and high risk patients, and the management depends on that. If it's an AFL, then the standard of care is enough. Fibrosis is there, then standard of care of F1 is enough. But if NASH or fibrosis is there, then you have to use specific drugs for diabetes, like pioglitazone, GLP-1 receptor antagonists. And if you have NASH cirrhosis, you individualize. So this is a flow chart which is used these days. First, you have a non-invasive testing by FIP4 score, as I have told you, or NFS. If it's low risk, repeat in 2 to 3 years. Intermediate risk, then you go ahead and do a FibroScan. If there's low risk, repeat in 2 to 3 years. High risk, refer to a gastroenterologist. Now, this is a flow chart showing you both the pathogenesis and the pharmacological therapy, and what is the value of and how it is useful. So you have lifestyle intervention, then what you can do is physical activity, exercise, and time restricted feeding. That is helpful to prevent to negate the secondary lifestyle, high fat diet, and gut microbiota symbiosis. You have insulin sensitizers like thiazolidines, metformin, and MSTC 06026. This will reduce insulin resistance. Then you have antioxidants, which will reduce lipotoxicity. Then you have FXR agonists, PPR agonists, which will modulate the nuclear transcription factors. Then you have thyroid mimetics. Then you have anti-TNF agent neutralizing antibodies. You have cholesterol lowering drugs that will reduce the lipid load. Now, these are the commonest drugs which are used for NAFLD, and drugs with histological proof improvement in NASH are vitamin E, but vitamin E is not used in diabetics because studies have shown that it's not useful in diabetics. Pioglitazone is a very, very useful drug which is used when it's not, and which is cost effective and is useful in diabetics with NASH. Then you have GLP-1 agonists like liraglutide, semaglutide, tetrarzepatide, then SGLT2 inhibitors, EMPA, TAPA, saroglitazar. Drugs are known to and have a histological proof of improvement in NASH. Then you have drugs without any histological basis like UDCA, statins, metformin, DP4 analogs, Elverman. Thank you. Any questions?
Very important talk, actually. This is not related to cardiology, but I think it's a common thing to have it. So I missed the conclusion part of this, but the query which I have, maybe anybody have a question? Yeah, you can please take the mic. Give the mic to him.
Thank you, sir. Thank you for the lucid talk you have given, sir, on NAFLD. So just to add one point, nowadays the NAFLD term has been termed as an obsolete term. The MASLD is being used nowadays, the metabolic associated steatohepatitis.
Actually, I had only 10 minutes. So
Yeah, sure, sir, sure, sir.